Nivian. Good morning, Aditya sir. Good morning, Mandar. At the outset, I would like to thank Mandar and for inviting me for this session and this very good course on which we'll be talking about intrascleral or scleral fixated IOLs. So my topic, I'll start off with my topic immediately. Yeah, so IOL implantation in eyes with no or inadequate capsular support is a challenging scenario, and there is no universally accepted single technique that can be said that this is the one. However, the options available are anterior chamber intraocular lens implantation, scleral fixation of intraocular lens, which could be in the form of either sutured IOL, the glued IOL, or the flanged IOL, and iris fixation. So I'll be just giving an overview of how we are talking on this particular topic. The anterior chamber IOL, we all know the few advantages and quite a few disadvantages of this technique. I wouldn't be talking much on this because we all have kind of come out of it, and most of the VR surgeons would rather prefer going ahead with a scleral fixated IOL after a good anterior or maybe a complete posterior vitrectomy. But yes, this IOL placement technique is useful, especially in camp settings where anterior segment surgeon does not have access to vitrectomy machines, or the anterior segment surgeon does not have access or cannot refer his or her patient to a VR surgeon for the needful. So ACIOL, I wouldn't say it is completely out of vogue, but it is slowly dying off as a technique to be used on a routine basis. So then we go ahead with scleral fixated IOLs. We have commonly been using these two techniques. One is the conventional 9-0 or 10-0 proline fixation, which could be either a single knot technique or two point fixation techniques, or the Gore-Tex suture fixation technique, which is a 4-point and gives a better fixation. Additionally, the Gore-Tex, I had presented this in the last AIOC. The Gore-Tex is a suture material which doesn't get disintegrated. It is also a very, it doesn't cause any tissue reaction as such. So it's a very stable kind of a suture, and the lens stays stable in the eye in the position that the natural lens is. Moving on to intrascleral fixation techniques, we routinely use the glued technique, which was started by Dr. Amar Agrawal from Chennai, and he mastered the technique. He has brought it to the world, and it's been something which has been used quite a lot in the past few days. But then there is a newer technique which has come up, which is the flange technique, which would be mainly discussed by Mandar after I will be finishing my talk. So in this, we start off with marking the axis at which we want to keep the lens, put the lens inside, and also mark the 2.5 mm for making our flaps on the sclera. Once that is done, do a good cautery and marking of incisions for the flap on the sclera. Then with the flap is made with a then we fashion a flap in that particular area. In the partial thickness scleral flap is fashioned on one side and then on the other side as well. Once the flaps are made, we make a AC maintainer port in the sclera, and the AC maintainer is placed. Next comes with the MVR, we make scleral incisions so that we can pass the haptics of the lens. And then after making a clear corneal incision, we with a hand holding technique, we would catch hold of the haptic on one side, and it is then brought out through the same scleral opening, and then the other haptic is slowly brought out through the other opening. Once we have externalized both the haptics, we make a small lamellar tunnel with a 26 gauge needle, and the haptics are railroaded into these small tunnels which are made there. Once this is done, the flaps are placed back in position after applying a drop of tissue glue, and then the AC maintainer is removed and the lens pretty much remains stable over there. So once this technique is at the end of the procedure, we would just place, I tend to do a small air bubble being placed inside the eye just to, in the anterior chamber, just to be sure that there is not much of movement of the lens and it remains stable. So this is what I would wanted to present as a glue diode technique over here. From here on, I will hand it over to Mandar, who would be presenting the similar kind of a scleral fixated technique in the flanged eye. Thank you. Okay.
Thank you, Shamik, for the sum up overview of the current situation. So we'll take up from there. So we'll describe the next newer advances in the intrascleral fixation now. Just a minute, I'll share the screen. Can you turn off the timer, please?
Yes, Dr. Mandar, I'll take care of it. Don't worry.
Mandar, can I ask a question?
Yeah, please.
Shamik, is there any tips for youngsters when they're learning the procedure? The most common thing I find is when you're doing the second haptic, sometimes the first haptic tends to slip out. I'm not able to hear you. You're muted, Shamik.
Shamik, please unmute yourself.
Sorry. That does happen, especially when initially when we are very new to the technique. Has happened a couple of times with me, and then you really have to fish that previous haptic back out and bring it back in place. What initially we can do is we can ask one of our trusted assistants. I'm calling here trusted because he or she has to be very good at what they are doing, because they have to hold the haptic very gently, because if they do it very, if they hold it very strong with the forceps, it can break. So we have to ask the assistant to hold the haptic for the time being, and the other thing that we can do is we can do a handshake of the other haptic as well with two forceps. One forceps pushing the haptic inside, the trailing haptic, and the other forceps catching hold of the haptic from the other side. So that way the IOL can mostly stay in place, and the first haptic won't roll back inside the eye. I think I have answered your question. Is it okay, Nivya?
Yeah. So somebody holds it, sometimes they tend to bend it, and then tucking it inside also becomes difficult.
Yes, that's why I said that a very trusted assistant would be helpful over there.
Thanks, Shamik.
The technique was described that you hold some kind of silicone piece.
I think Prabhu Bhaskar, I think in Aravind they're doing that. The stopper was.
You talk on that, I think.
Yeah. Thanks for including me in this wonderful webinar. Most of the times I don't trust my assistant. I always use silicone stopper in XNet, so that saves time and avoids hassles.
I think he'll cover in this presentation.